20 countries worldwide. On my function, orthodontics, to dentists, orthodontists, to sleep physicians, to physiotherapists, etc. He has been in general practice for over 50 years. Without wasting time, he has a very long profile. Let me take this opportunity to welcome Dr. John Flutter to start his presentation. Dr. John, you're welcome. It's nice to have you here.
Can you see me or hear me?
Yes, we can see the screen with 2 slides.
With 2 slides. I can't do it. We're just going to have to carry on with seeing the 2 slides. I'm happy to carry on. It's just that you get the presenter image and I get the image that you just won't allow me to turn around. I'm happy to carry on though.
It's fine, Doctor. Let's go on.
Okay, let's go. So thanks for the invitation. Sorry that we're a bit late getting started. How are we going for time? Okay, so a bit late starting. So Class 2 malocclusion. When I was an undergraduate, this is what we were taught. This is from an orthodontic textbook. When we're looking at Class 1, Class 2, Class 3, we're essentially looking at the relationship between the mesiobuccal cusp of the upper first molar and the buccal groove on the lower first molar. And the relationship between those two positions determines whether a Class 1, Class 2, or Class 3. My slides aren't moving on. It just isn't working. The technology just isn't working between us. My keyboard's totally frozen. It won't do anything. Can you still hear me?
We can hear you, sir.
And why can you see a frozen screen the same as me?
Yes, we can see the screen.
And I can't even go to stop share now that my cursor's completely lost. I'm completely frozen out again.
We can do it like this.
I'm sorry. I could send you a Zoom link, but this Zoom link just frankly isn't working. I use Zoom all the time. I don't think it's. Well, I don't know. Who knows? The technology somewhere between us is not working. Is the slides moving now?
Sure.
Oh, okay. Oh, it's moving. If you can you see 1 or 2 slides?
2.
Okay, so it's moving again now. So that's what we were taught as undergraduates. We were taught that Class 1, Class 2, 3 was basically always assumed that the maxilla was in the correct position. And it's just making it really slow. It works a bit slow. But basically, the idea that the maxilla is always in the correct position is not accurate, because in malocclusions, it's the maxilla that's in the wrong position just as much as the mandible. And it just, I don't know. My computer just is not working. Oh, there it is. Yeah. So this was known like years ago that mouth breathers have their mouths open most of the time. And so these kids have all got their mouths open, and we know that when their mouth is open, they're mouth breathers. When they're mouth breathers, the maxilla is set back within the cranium. And if everything's set back within the cranium, then the relationship between the upper and lower molars is not as important as the relation between the upper jaw and the rest of the head. So so it just freezes it and then it might go forwards. So So that's the problem, that the kids got their mouths open and their mouth breathing. And as a result of that, the maxilla has dropped down and back, and the mandibles followed down and back afterwards. And that's what John Mew said in his tropic premise. That was exactly his point, that the ideal development of the teeth is dependent on having the lips together, the tongue in the roof of the mouth, and that means that you have to breathe through the nose. And most kids have their mouths open most of the time. As you know, I was in Uganda recently, and this is one of the schools that we visited, and the kids there are just the same. The children in your population, the same as the children in, this is a population in Australia I can show you on the screen. But most kids have their mouths open most of the time. And as a result of that, the upper jaw tends to drop down and backwards. And when it drops down and backwards, crooked teeth is just one of many other problems that result in that, particularly breathing disorders. So if the upper jaw is down and back, the relationship between the upper and lower jaws is important, but it's the position of that upper jaw that controls the airway. And sleep breathing disorders and crooked teeth and jaw joint dysfunction all go hand in hand. And snoring's bad, but sleep apnea, when you stop breathing in your sleep, is a much more serious problem, and it's affecting more and more children worldwide. What we used to think of as something that affects old men or obese men now is affecting kids. And it's prevalent everywhere. It's not often I get invited to a first birthday party. This is the granddaughter of a cousin of mine. And I go there and I see she's got her mouth open. And I know her tongue is low. And I know that the cranial development won't be ideal, and that will be reflected in her teeth. It'll be reflected in her breathing. It'll be affecting her sleeping, because breathing and sleeping go hand in hand. And so when I see these underdeveloped jaws, upper jaws, it's not so much the relationship between the upper and lower jaw I want to improve, although I often do want to improve that. What I want to do is to improve two things: the relationship between the upper jaw and the rest of the cranium, and then the relationship between the upper and lower jaws. But getting the upper jaw, the shape and the size of the tongue, is what normal growth and development would result in. So ideal growth and development, the upper jaw is the shape of the tongue, the teeth erupt around the tongue. But if, as what I'm showing you now, we've got an anterior open bite and a bilateral posterior cross bite, this is morphs over several years of treatment. But we made the top jaw bigger, trained the tongue to support that upper jaw, and then by learning to breathe through a nose and keep her lips together and the tongue in the roof of the mouth, the result is stable. The tongue keeps the pattern stable. So if you look at this boy, what can we see there? What can we see going on there? Mouth's open. A lot of muscle effort on the swallow. Can you see that? See the tongue pushing forwards? Anterior open bite. But the problem is not the relationship between the upper and lower jaw. The problem is the upper jaw has dropped so far down and back that when you see the picture of him with his lips together, he's using his mentalis, his chin muscles, to bring his lip together. And he can't eat properly. the upper jaws, instead of growing forwards, has grown more downwards because the tongue just hasn't been there supporting it. And that upper jaw, if you looked at take the tonsil's view of the upper jaw, you can see that's the space. That's what that tongue is developing. And that process starts in the first minutes of life. This infant is actually less than 10 minutes old. And in order to get the milk from the breast, the English word for that is suckling. But in fact, we don't want to suck. What we want to do is we want to pump. The infant, when it finally gets the spot, will pump the milk from the breast. You don't get that, you only get one atmosphere of pressure when you're sucking. You need to be pumping. And it's that pressure between the tongue and the palate that is the pump. And the tongue and the lower jaw are a single unit. You cannot move the tongue up and forward without moving the lower jaw upwards and forwards. So the tongue coming up and forwards and developing that upper jaw gets the upper jaw in the best position, the best shape, and the tongue brings the mandible up with it to match the growth and development of the upper jaw. And so when the infant wants to suckle at the breast, that tongue and jaw comes up and compresses the breast tissue between the tongue and the palate. And the energy from that comes from the muscles of mastication, particularly the temporalis. So the temporalis muscle is the principal muscle for bringing that that lower jaw upwards and forwards. The masseter is very important for chewing and grinding the teeth, but the temporalis is the muscle that brings that upper jaw, that lower jaw upwards and forwards, compresses the tongue onto the palate, which compresses the breast tissue between the tongue and the palate. And the more forward the maxilla is and the bigger the maxilla is, the more the nutrition the infant would have got. And so the growth and development of this whole structure is reliant on developing good musculature, muscles of the lips and muscle of the tongue. Lips get at rest, tongue in the roof of the mouth. And to do that, you have to breathe through the nose. And most children have their mouths open most of the time. And so that upper jaw doesn't develop to the correct position within the cranium. And then the relationship between the upper and lower jaws, then, it's not that it's not important, but that's secondary. You can have a crossbite, anterior crossbite, or bite, or you can have a big overjet. The problem, the cause is essentially the same. And a large part of the treatment, if you're treating young children, is almost the same. Whatever the dental pattern is, what you're dealing with is a maxillary arch that's dropped downwards and backwards from the ideal position. So I did some work with appliances called trainers in the 1990s. And I had some material published based on 10 cases. We went and put them on a scanner, models before, models afterwards. And it's the only properly article in a proper peer-reviewed journal that I've actually had published. And it talks about the changes, these children in the early mixed dentition. And once we used a Maya brace, or it was called a trainer in those days, to train the lips to be together, to train the tongue up into the palate, which is what the purpose of the trainer and the Maya brace is, then we supplement that by teaching them how to breathe through the nose. And then these photographs are taken 1 year apart. Well, the models are a year apart. And so the children, all of the 10 children in the study, 10 consecutive cases treated only with these trainers, they all showed improvements, some more than others. This was one example. This was quite a nice change. There you can see how that upper arch has developed, and as it has the lower. Look at the shape of the upper arch on the right there, where there's much more room for the tongue, and the upper incisor being proclined by the tongue. And I like to get the noses parallel if we're going to make these comparisons. But I can see how that whole upper and lower jaw have come forward, and the lower jaws come forward in relation to the upper jaw. So first of all, the upper jaw comes up and forwards with the tongue, bringing the mandible with it. And the lower jaw grows to the position the child usually holds it in. And if the lips are together and the tongue's up in the roof of the mouth, the tongue will bring that lower jaw upwards and forwards with it, which you might call a class 2 correction, but really it's a correction of the upper jaw position as much as the lower jaw position. But if you want to talk about class 2 patterns, I mean, I think you'd agree that this boy on the left is got a class 2 pattern, and you can see the arch form, and you can see the occlusion there, that narrow upper jaw, which develops into a much better shaped upper jaw with a much better development in the anterior area. And we need to distinguish between two different things. We need to distinguish between muscle function and muscle posture. So if you look at the girl on the left as she's swallowing, what we're watching is what she does in function when she swallows. On the right, what we see is her posture. That is how she's at rest. She has a lower lip trap. The tongue is between the posterior teeth. That's what gives us the deep curve of spee. So she's at rest like that, the lower lip trap behind the upper incisors. And then when she swallows, she sucks the upper incisor up and backwards. She breathes through her mouth all the time. So one of the challenges is to help her learn to breathe through her nose. So oddly enough, what you have to do in many cases is to make the top jaw bigger, because when you've got that narrow tapering upper jaw that you can see there, and when you can see, I mean, I don't use cephalometric very much, but even if you do traditional cephalometric pattern, you can see that she's a really tough orthodontic case, skeletal open bite. You can call it different things, high angle, clockwise grower. It's all different ways of saying that the maxilla and the mandible has dropped down and backwards. And when you look at the AP view, you see that lengthening of the lower face as the lower jaw drops down and back. And sometimes oh, you can't in this case, sometimes you can see the airways restricted on the cephalometric X-ray. It's obscured on this picture. But the solution is to keep the lips together, tongue in the roof of the mouth, and breathe through the nose. And I've used, over the years, I've been doing this for 40 years. There's a heap of appliances that will do that. But it's not the appliance that does it. It's the child learning to keep their lips together, tongue in the roof of the mouth, and they have to breathe through the nose. You can't do that for them. And to some degree, they need to want to do that. So if you want to get the better relationship between the mandible and the maxilla, which is what correcting a class 2 malocclusion would imply, getting that lower molar forward in relation to the upper molar, then if you want the lower jaw forwards, you bring the tongue forwards. And to get the tongue forwards, you need the tongue up in the roof of the mouth and the lips together. And for that, they have to breathe through the nose. And for many children, the principal problem is they find it really difficult to breathe through the nose. But if you do get them to make those changes, then you get a better relationship primarily between the maxilla and the rest of the cranium, which, because the maxilla is the breathing apparatus, you get much better daytime breathing, and you get much better, in particular, nighttime breathing. And nighttime breathing is what's really critical. That's when the brain heals. To have the ability to breathe through your nose all night is a huge improvement in your health. You go to sleep well, to sleep deeply, to get proper regeneration of the neural tissue within the brain. And for that, you need to get into deep sleep, uninterrupted sleep, snore-free, sleep apnea-free sleep. Because we make this distinction between what class 2 is. So if we say where the ideal position of the jaw should be, and see where the jaws often in reality do grow to when you get a big overjet, you think the problem is in the lower jaw, but the problem is that the upper jaw is set back and the lower jaw is set back even further from that. And so very often when I start treatment, paradoxical as it may seem, I often increase the overjet when I start treatment because I want to get the mandible forwards. So I've got to get the maxilla forwards. I like to get the noses parallel so you can see the change. I think it's better evidence. But you can see that on the right side, that's the bit that's missing, upper and lower jaw. And the challenge is to try and correct that. And you say, oh, I can't tell where the lower jaw is. You look at it. I've taught this material throughout the world, and in most parts of the world, we do hands-on sessions, and I show you how to look at the cranium, where the landmarks are, how to recognize where the frontal bone and the zygoma and the maxilla meet, and when it meets well and when it doesn't meet well. And you can see just by looking very often. And so the other thing to make sure is that when you have these large overjets, you need to get the lower jaw upwards and forwards. You want to try and avoid putting pressure on the upper jaw. So you're encouraging and supporting the children. You're doing exercises, you're doing breathing exercises, you're doing postural exercises, helping them and encouraging them and supporting them to keep their lips together and the tongue in the roof of their mouth. And so that in this case, after I think it was 2.5 years of treatment, we then finished the treatment, saw her every couple of years, and females stopped growing at age 15.5. This is the same girl, no treatment, no retainers, no braces, 15.5 years of age now. So the cranium is fully grown. This is what you see now is what you get. Nicely developed upper arch. But look closely at those lower incisors. The lower incisors are crowded. I don't have to justify that, I don't think. That is the best that she could do. She was the one who made the changes. We gave her the opportunity. And if we'd started earlier, it would have been easier. But what she's got a functioning nasal system. She can breathe through her nose. She sleeps breathing through her nose at night. So lips are together at rest. And so she gets the benefit of good sleep. She gets the benefit of being able to do better exercise because her breathing is better. So I make no excuse for that, because what we've done is we've manifestly improved the way she is. And a huge, you talk about class 2 correction, okay, the mandible is much better positioned towards the maxilla, but it's the maxilla within the cranium that I think the special effect of the treatment is. And yes, she does have crooked lower front teeth. Yes, she does. That's true. But let's get those back. Yeah. But if you look at that face, I mean, you could honestly say she's the girl with the crooked teeth. I mean, you and I were dentists. I can see that lower right lateral incisor slightly overlapping the canine. It's true, it is. But I mean, we've changed the whole of her breathing pattern, her health, her appearance, her whole outlook on life has changed. We've got a healthier child. Those big overjets were a sign of poor health. And it's a health program. And when you get better breathing, better lip posture, get a better tongue posture, you're healthier. So this is the danger. The top features are where I'm using the patient, the individual, the young person themselves to bring their lower jaw forward themselves. They've got to bring that forward under their own effort. If you try and hang the lower jaw off the upper jaw, the danger is what we see here at the bottom. I mean, I treated this. I treat this with a twin block. This is an older case. And so what my concern is that this is what I was doing as an undergraduate. We were taught basically we did it by extracting teeth. I didn't extract teeth in this case, but you basically turned a class 2 division 1 into a class 2 division 2. It's improved. I mean, I was quite pleased with the change she made. She definitely moved forwards, but that's the danger of using just mechanics, just mechanical appliances to try and bring the lower jaw forwards. If you want to get that lower jaw in a better relationship to the upper jaw, what you have to do is to get a better relationship between the tongue and the palate. And to get a better relationship between the tongue and the palate, you have to be breathing through your nose. And you say, what, when should we be breathing through the nose? Well, you should be breathing through the nose all the time. And if you want to try and talk children into doing that, then at some level you need to be doing that yourself. And when I say breathing through your nose all the time, most adults have their mouths open and breathe through their mouths when they do exercise. And if you have your lips together and breathe through your nose all the time, you do all your exercise breathing through the nose. And here you can see, I'm talking about class 2s, but you can see an anterior crossbite thing. Oh, class 3. And it's going to be really tricky. But it's nothing to do with mandibular overgrowth. The maxilla is way, way back from where it should be. The mandible is back from where it should be, but the maxillae are way back. So there's 12 weeks between those two images. That was semi-rapid expansion and a forward pull headgear, and it transformed the girl's life. 12 weeks between those. And that's nothing. The mandibles come forward. Look at her neck. You see that it's not perfect image on the left of her profile, but can you see that her tongue? That's that convexity under a chin reduces. The tongue comes up and forwards. You don't see it hanging down below your chin. 12 weeks. And then what you have to do then, doing the mechanical change is one thing, which I've done there. That was 12 weeks. Then you've got to get the tongue to support it. So the first part is actually the easier part. Getting the structure right is the easier part. So this is a different example. But when you start off with a pattern like that, here we've got a bilateral posterior crossbite, verging on an anterior crossbite and an open bite. Again, an underdeveloped maxilla. And so what I do is I develop the maxillary arch. And the teeth are all a bit higgledy-piggledy all over the place, so I'm not worried about that. All I'm trying to do is to make room for the tongue. Because once I've got the room for the tongue, then I've got somewhere I can train the tongue to go into. If you say at that top picture, so the child put the tongue up in the roof of the mouth, then they might justifiably say, but there's no room for it. I can't get it up there. And my tongue isn't strong enough now to make it big enough like it would have been 4 or 5 years ago when I was 1, 2, 3, and 4 years old. So I make the top jaw bigger, and then you've got to get the tongue to support it. And that, in my view, is technically simpler, but in terms of delivery, much more difficult. Because you've got to encourage and support the children to keep their lips together and the tongue in the roof of their mouth. Now, I use appliances to do this. This isn't a commercial thing. That's what I use. There are appliances manufactured by a myofunctional research company, and in Uganda, I mean, they are extremely expensive, but it's not the appliance. I promise you, it's not the appliance. The purpose of the appliance is to train to have your lips together and the tongue in the roof of the mouth, and that's what they need to do, whether they use that appliance or not. And there's so much that you can do in terms of education. The key to this isn't the appliance, whether you can afford it or not. It's whether you can set up a facility, whether you can set up a program that encourages children to keep their lips together and their tongue in the roof of their mouth. Because it's not something that you apply with, it's not a product I'm selling you. It's a training or teaching program you're trying to sell to families. And the reality is, if you're trying to deliver a program like this, the challenge is to make it in such a way that we're dentists. We want to make a living. We want to make it profitable for our dental practices. But at the same time, we need to make it affordable to families. That's why we use educators working with children in groups. Children learn better when they're in groups. You can give them individual care within the group. And it's the delivery of the program that's probably as important as the bits and appliances. And so that's largely an educational program. And it's teaching the children to get their lips together and the tongue in the roof of their mouth, because mouth breathers, all children have their mouths open. Most of the time are breathing through the mouth. What happens is the lower jaw falls open. The tongue drops from the roof of the mouth. With the mandible, the tongue and the mandible move as one. As soon as the oral airways open, they're mouth breathers. And these two you can see on the screen now, one has got a class 2, you call it. He's got a big, an increased overjet. The girl on the bottom, you call her a class 3. In fact, they're both what I would call a class 4. Class 4, when both the maxilla and mandible are set back within the cranium. And you can have an anterior crossbite if the maxilla is set relatively further back, or you can have an increased overjet when the mandible is set even further back than the maxilla. But it's the maxillary position that's so critical in airway, and particularly in sleep. And so I know what the problem is, and I know what the solution is. The challenge isn't knowing what the solution is. The challenge isn't whether you can afford to buy a particular appliance or not, or make a particular plate or fit a particular bracket. The challenge is, are you able to deliver a program to help children to do this? And I've spent the last 40 years doing that. And I've set up systems to do that in Australia, and I've also got a practice in Ukraine and Kiev, and I've set up a system there. And it requires 3 things. it requires a location where children feel comfortable. You can't do it sitting with a child sitting in a dental chair. When they're sitting in the dental chair, they are in sympathetic mode. They're not learning. Parasympathetic mode, rest and digest and learn, as opposed to sympathetic mode, which is flight and fright. Sitting in a dental chair, you're worried, you're anxious. You're not going to learn then. You've got to create a situation where the children can learn. You're a trained educator. You can train assistants to do that far better, to relate to young children, understanding their culture, understanding what the children are interested in, getting engaged with the children, and seeing more than one child at the same time. The Chinese have a proverb. It, it, to cook one egg takes 5 minutes. To cook 10 eggs takes 5 minutes. Children learn better in groups. You can make it affordable for families and at the same time profitable to deliver the system. So I'm really pleased to try and tell you what I know about correcting class 2. And the management of the malocclusion is essentially managing the growth and development of the cranium. And so you need to be able to identify poor cranial growth and development. And as a dentist, it's really, really super easy, because all you've got to do is look at the teeth. Crooked teeth is a sign of poor cranial growth. Poor cranial growth is a sign of poor health, manifested in poor breathing patterns, and particularly poor breathing patterns during sleep, with snoring and sleeping apnea becoming increasing problems with children who are growing. And it's treated by far the best time when children are in the early mixed dentition. By the time that those 28 permanent teeth are erupted, by the time they've got the only in the permanent dentition, if they come into you then, it is possible to help them and make changes, but it's much easier, much easier in the early mixed dentition. They've got so much growth in front of them. The maxilla, they've got 12 baby teeth at least that to change over, hopefully 14 or 16. And you've really got something to work with then, something to try. And also, the children do much more like you ask them to do at that age, 6, 7, 8. See, like these children here, this is a breathing program I used to run. Still do, teach people how to do it. 1 trade assistant, 8 children, 8 parents. You teach the parents, you teach the children. These are special breathing monitors. You don't need the equipment. I was a pioneer in this field, and I needed some numbers to back up what I was teaching the children. We know we need to sit up straight. We know we need to get the diaphragm working. We know we need to slow down the breathing the breathing frequency. That's how you manage class 2 malocclusions, trying to help the children to grow better balanced jaws, and both better related to the remainder of the cranial bones. In particular, how well the upper dental arch produces a good functioning airway. So I'd like some feedback or some questions from some of you now, if that's possible. Yeah.
All right. Thank you very much, Doctor, for the presentation.
Does anybody got any questions or?
Yes, we have a hand up from Dr. Aisha. Dr.
Yeah.
Aisha, you're welcome.
Thank you, Dr. Flutter. Thank you, Dr. Matovu. Mine is not a question, but a comment to echo what you said, the importance of looking beyond just the static occlusion of the teeth and looking at the face, the profile, how this child has grown, and how all of this affects and impacts treatment decisions. Certainly, a lot more should be paid, attention should be paid to looking at that as opposed to the conventional way of just treating an occlusion. So thank you for pointing out the dimension of soft tissue, the dimension of growth, and the dimension of really understanding where the problem originates and trying to treat it at its root cause. I'm just echoing what you've said, and you're absolutely right.
All right.
Well, it's good to know that you have already arrived at a very similar position to me on this. I mean, that's really encouraging, and yeah, that's really good to hear.
All right, members, any more questions? Any questions? Anyone with a question can type it in the chat or can raise up your hand. We'll give you time and speak.
Well, if there's no other questions, I mean, it's a real pleasure. I had a really good trip to Uganda recently, and we traveled around Uganda quite a bit. We went to 3 schools there that a friend of mine helped set up in Uganda, and we did some dentistry there out in the bush, and very basic primary care. Yeah, I felt very welcome when I was in Uganda.
Okay, doctor, I have a question. Do you apply such a treatment in adults?
You need, in my view, you need to have a system set up to treat children before you try adults. Adults, it's even more important that you work on breathing. And if you're having an adult sitting in your dental chair, unless you've got a program set up, if you're trying to talk to an adult in the dental chair about breathing, you'll talk for hours and hours. You've got to, in my view, adult treatment is the same. It's just the delivery of it is even more important. Is that you need to get a system up for delivering a breathing program before you start treating adults, and get that together, because it's much easier on kids. Getting children to get their lips together and their tongue in the roof of the mouth and breathe through the nose is much easier on young 6, 7, 8-year-olds, is much easier than 12 and 13-year-olds, and 12 and 13-year-olds are much easier than 25, 35, 45-year-olds.
Sure. Right, members, anyone with a question? All right, okay. All right, I think there are no more questions. Let me take this opportunity to welcome Dr. Aisha to say something before we close.
Fine.
Dr. Aisha is a pioneer orthodontist in Uganda, actually.
Thank you, Dr. Matovu. Allow me to move a vote of thanks to Dr. John Flutter. Dr. John, you have very selflessly shared from your vast wealth of knowledge and expertise on the management of class 2 malocclusions. I've had the pleasure of listening to you before, and I know, and I'm sure my colleagues share the sentiments that I have when I say you're very gifted in teaching. You're able to explain very simply and yet precisely probably one of the most controversial treatment concepts in orthodontics. Yes, thank you for making it easy to understand class 2 malocclusions, the importance of early intervention. And I for one, and I'm sure we shall all approach our treatment of these complexities very differently now that we know more and we know a little bit better. Yes, and so on behalf of the Uganda Dental Association, Dr. Flutter, thank you so much for an informative and stimulating evening. I'd like to thank Dr. Mark Lynch. Please pass on our thanks to him for making this introduction. Yes, and now that you are friends of UDA, we're looking forward to more interactions in the future. We look forward to welcoming you back into Uganda. And yeah, thank you very much. We really hope to hear from you again.
Thank you very much. I think the students are really lucky to have such an enlightened head of department, orthodontic department. I mean, very different from when I went through, I assure you. And just understanding it and knowing it, because once you know this, you can't unknow it, really. And I'm really encouraged that more and more people worldwide and more orthodontists worldwide are becoming engaged in this conversation. So thank you.
And perhaps, John, the emphasis on diagnosis and treatment planning cannot, I mean, that's an aspect that we can't overemphasize. Not all malocclusions will be the same, but it's important that we recognize those that we can treat and recognize the way in which we should treat them and approach them. And the dynamic examination that you do of talking to the child and just seeing how the soft tissue is interacting with the dentition, how they're smiling, their profile. I think all of that is something that we probably don't pay as much attention to as we should.
Yes.
Patient sits in the chair, we slap them supine, and we quickly start to examine. And I think there's a lot we miss out on just looking at some of these videos that you incorporated in your presentation. There's quite a bit of information that we miss just by not talking to the patient and interacting with them at an eye level, as opposed to just, looking at them in the chair. So like I said, I'm hoping that we can approach these treatments with just a little bit more, humility, that we perhaps need to look at a little bit more than what we have been normally looking at, but also with a better understanding of the interactions between the soft tissue, the hard tissue, the muscles, the lips, the cheeks, the mandible, the growth patterns, and all of that, and not just look at an occlusion. Thank you.
Thank you.
All right. Members, anyone with a question? We still have some more 2 minutes. All right. To supplement on Dr. Aisha's word of gratitude, we take this opportunity still to thank Dr. John Flutter for giving us this presentation. Dr. John, thank you very much.
My pleasure.
All right. I think there are no questions. Let me take this opportunity to close today's session. Have a very nice weekend, everyone.
Thank you.
Thank you.